And so, for those of you who aren't familiar with ECHO, this is really about community and about case-based learning. So, we are gathering to learn from each other as well as from our subject matter experts. We will kind of take turns bringing in whatever cases that we have. Please, no HIPAA. But otherwise, bring in those patients that are keeping you up at night or that you're taking home with you that you're thinking about. No need for a pretty bow all wrapped up. Open questions are the best. Say, this is my patient. Have a question. What do you guys think? And so, what really makes this work is that we trust each other, that we're helping each other out, and we're supporting each other through some of those like really difficult like clinical quandaries that come our way. And so that's really what ECHO is all about. So think if you have a case today, somebody with ADHD that has you kind of scratching your head, please feel free to send me a quick note and to let me know that you want to share so that I know to turn the mic over to you a little bit later after Lauren has the chance to finish sharing today. Next slide, please. Just a little bit more housekeeping here. Um, we are going to be meeting second Fridays of every month at noon for the next 6 months. Those who attend all 6 sessions get this like cute little CalMap core badge. We'll send you the certificate. So you can like put this on your LinkedIn. You can stick this on your wall. You can put this on your CV just as proof that you are really committed and to training yourself in pediatric mental health. We'll be recording the didactic sessions only, not the case discussion, so we can post these recordings onto our CalMap website. Please, 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 this is interactive. There is no such thing as a bad question.
There's always something to see. There's a
Okay, so whoever, like, otherwise, let's stay muted until we're ready to speak. But there is no such thing as a bad question. And I've had some really respected pediatricians who've been like kind of like pillars in the San Francisco community saying, feel like interns again. And that's just a common feeling. And so let's bring these questions and help each other out. Last reminder, this is hot off the presses. The CalMap line is now open until 5 p.m. So if you have a question and you can get on before 5, we will take those calls. We now have consults available online too, and those are available 24/7. So that's email style through our portal. If it's a more simple, straightforward question, you can send that, and one of our consultants will email you back within 24 hours. So that's hot off the presses. Wanted to let you know that this is available, and you can also just pick up the phone and call. The easiest way. And with that, let's go on to the next slide. I'm going to turn the virtual mic over here to Dr. Schumacher, to Lauren, to give us our talk on ADHD.
Thank you so much. So today I'm going to be talking about ADHD, and as Joanne mentioned, this will be a brief whirlwind talk, so we have time for discussion and case discussion at the end. But hopefully by the end of this, you'll be able to define the elements needed to diagnose ADHD, list first and second line treatments for ADHD, describe some common side effects and their management, and identify when to refer to specialty mental health. So briefly to start with, I think a very helpful guide for thinking about ADHD generally is the AAP practice guidelines, which were updated in 2019 and kind of go through that kind of evaluating 4 to 18-year-olds with concerning symptoms for ADHD, thinking about looking for DSM criteria, assessing for co-occurring differential physical and mental health conditions, and then using a chronic health condition approach for treatment. So and then kind of thinking more broadly, I think it's helpful to think about there was this interesting study that looked at kind of different practice guidelines. So we had the AAP practice guidelines, but also practice guidelines from Canada, UK, Australia, and found commonalities across all of them, which included kind of screening patients with mental health complaints for ADHD, using a mix of kind of the clinical interview and rating scales, a complete history to help diagnose it, that you kind of don't need to be doing laboratory neuroimaging or psychological testing to diagnose it, that it's a clinical diagnosis, to screen for common comorbidities. And then that medication and behavioral treatments are the mainstays of treatment, that there isn't good evidence at this point for alternative therapies like special diets or neurofeedback, and to approach it as a chronic condition, and that routine ECG pre-screening is not required if there is an unconcerning cardiac history. So I think those are some of the essentials that are kind of a common approach in a number of different places. So kind of dive in a little more specifically when have suspicions, we're hearing concerns about attention or behavior in school, we're concerned about ADHD, we want to be looking for at least 6 symptoms of inattentive or hyperactive impulsive symptoms. We want to see that they're present before age 12, have been persistent for at least 6 months, so it's not a new transient thing, that's something that's been persisting, and that at least several of those symptoms are present in multiple settings. So most classically, that might be home and school, but that also might be in activities with friends where we see issues, and that they're impairing functioning and that they're not better explained by something else going on. Because it's a lot of symptoms to go through, like those 18 different symptoms are possible for ADHD. It's really helpful to use an ADHD rating scale. These are a couple that are free. There's the Vanderbilt assessment scale, which has both parent and teacher ones. It has kind of an initial one that screens for ADHD symptoms, but also oppositional conduct and some anxiety and mood symptoms, as well as functional impairment. And then there's also the SNAP, which has also a parent and teacher form and kind of an initial and follow-up form for tracking symptoms over time. And then there's also the adult ADHD self-report scale, which you can think about with using as well for teenagers to get that self-report. And it's helpful both to use these kind of at baseline to help with making the diagnosis and kind of giving yourself a baseline for assessing whether treatment or interventions are helping. And then kind of as you go along after changes in treatment to help track response to treatment. And then as part of the assessment, it's also important to think about kind of other things that might be either causing these symptoms or that might be comorbid with them. There can be a lot of different possibilities. Really, comorbidity is the rule rather than exception, with kind of 60 to 70% of people with ADHD having a comorbid psychiatric condition. And here we just listed a number of them, as well as some of the screeners that can be helpful for thinking through if are there sleep issues as well, is there trauma, which both of those can kind of look like challenges with attention or behavior. Are there concerns for autism or substance use? So thinking through all of that. And this is, I think, a good time to also think about calling CalMAP if you do have concerns about comorbidities or thinking through other possible differential diagnosis. We're always happy to talk and think through how to help sort that out. So in terms of treatment, for all patients, we recommend doing psychoeducation. So helping the family and patient understand more about what ADHD is, and kind of different strategies for helping manage it. Behavioral therapies is first line for 4 to 5-year-olds, and then is first line in combination with medication for 6 to 18-year-olds. And kind of two of the most common ones are kind of parent management training or behavioral parent training, and then PCIT, which is kind of parent-child interaction therapy and focus more on the younger kids. For all kids with ADHD, want to thinking about different school accommodations and interventions to help support them succeed at school. And then in terms of pharmacotherapy, thinking about FDA-approved stimulants as first line for 6 to 18-year-olds, and methylphenidate as second line for 4 to 5-year-olds that kind of are having still significant functional impairment despite behavioral treatments. So in terms of psychoeducation, The CalMap website has a number of resources for families that talk about ADHD. So definitely encourage you to direct them there. There's also some great books about like taking charge of ADHD, as well as some different websites like Attitude Magazine and Chad that have a lot of patient and family-friendly language and talk about ADHD and different things that can be helpful. And then if you're thinking about medication, ACAP has a very helpful ADHD parent medication guide that talks about the different medication options, common side effects, it addresses a lot of common parent concerns and questions about medication. And then in terms of behavioral therapy, these are some different things that can be helpful. And especially some of these are, easy enough to talk about that even in short visits, you can talk about some of them, even if they're not doing kind of full PMT. So one I like to especially emphasize is kind of attending quality special time. So often we'll see in kids with ADHD, they have these really negative interaction cycles with family members where, they're they're acting up or spacing out, not getting things done. I'm sure you guys have all heard about really challenging like morning routines where they keep getting distracted, the parents keep reminding them, the kid gets irritated with all the reminders, the parents getting irritated with having to keep reminding them and not getting out of the door, and now everybody's stressed and running late, and there just can be a lot of that. So encouraging families to set aside special quality time where they're kind of present with the kid. And I describe to parents it's kind of like a mindfulness exercise, right? They want to be present in the moment, phones away. It's a child-directed activity, so they're doing something the kid wants to be doing and non-judgmental. So, staying present and enjoying the activity with the kid, but not telling them what to do. So if like kid is, if they're drawing together and the kid, makes a brown sun, it's not the time to be like, no, suns should be yellow, or to correct them. It's a time to just be present in the moment and kind of try to put some uh, quality time together. Can give them kind of money in the bank for when they do need to make corrections at other times. So that's a nice one that is kind of relatively easy to do in a short visit. You can also encourage simple instructions, making sure parents are kind of in the room, making eye contact, touching the kid when they're telling them to do something, not trying to yell it across the room and then getting frustrated when the kid doesn't pay attention. And then a lot of praise and catching them being good. So noticing when they are doing desired behaviors and really emphasizing that. And then in terms of school accommodations, ADHD qualifies for an IEP or 504 plan as other health impairment. And to kind of get that process started, parents should submit a request for IEP evaluation in writing to the school, and that gets the process started. Different things that can be helpful include kind of preferred seating, additional time on tests, sometimes having options for like fidgets or ways to take breaks or have movement. And then there's the Attitude magazine has some helpful resources for that. There's also more information about school accommodations on our website. And then in terms of medications, there's kind of two big groups. We've got the stimulants, methylphenidates and amphetamines, and then the non-stimulants, which include the alpha agonists, clonidine and guanfacine, and the norepinephrine reuptake inhibitors, atomoxetine and viloxazine. And then in particular, the combination of alpha-2 agonists with stimulants is also specifically FDA approved. In terms of stimulants, these tend to be our first line treatments for ADHD, kind of in the 6 to 18-year-olds. They tend to be very effective with an effect size of around 1 and a response rate of over 70% to a kind of first trial of stimulant and over 80% with a trial of an additional stimulant if they don't respond to the first one. That being said, that still means that 30% are not responding to kind of the first trial of medication. So there's a significant subset that also don't have a response to it. In terms of side effects, the most common ones that I'm sure you guys have seen and come up a lot are like decreased appetite, weight loss. Those tend to cause a lot of challenges for kids and families. Sometimes sleep disturbance, stomach ache, headache. Less common, but ones we still see and want to keep an eye out for would be behavioral rebound, where we expect that as the medication's wearing off in the evening, ADHD behaviors are going to return because it's no longer there treating them. That being said, for some kids, the rebound is kind of this phenomena where they come back even worse than before. Um, so that can cause problems for kids and families. We expect to see some small increases in blood pressure and heart rate, but want to check vitals and keep an eye out for kind of more concerning elevations in blood pressure, heart rate, sometimes sweating, tremors, other things. And then very rare would be concerns for hallucinations, peripheral vasculopathy, emotional blunting, compulsive skin picking. And then in terms of managing some of those more common side effects with the appetite decrease, it tends to hit worse at lunch. So really encouraging kind of substantial breakfast, substantial dinner, maybe afternoon snack as the appetite's starting to come back to help make up for eating less at lunch. It's also important to get a good sense of their kind of baseline eating patterns because often kids with ADHD are already, even without medication, are not eating much at lunch. If you think back to your own classroom or school setting and the lunch setting, it's often very loud, very chaotic, a lot going on. So the kids with ADHD before the stimulant is even on are, running around and looking, talking with their friends and not eating their lunch at all. So it's helpful to have a sense of that baseline so that you're not chasing not blaming the stimulant for not eating lunch if they weren't doing that before. You want to kind of monitor weight over time. So sometimes you'll hear about a decrease in appetite, but you'll see that they're still having good weight gain and growth, and then we're not too concerned about it. Other times we may start to see a drop in weight, and then we want to kind of try to troubleshoot that more. In those cases, sometimes drug holidays can be helpful, so having them not take it on weekends or not taking it over the summer, depending on kind of their specific symptom profile, or calorie supplementation with like calorie shakes or things like that can be helpful as well. If they're having stomach aches, making sure they're eating something before taking the medication. If there's issues with sleep disturbance, first finding out when they're taking it during the day. If they're a teenager and they're sleeping in and then taking their long-acting stimulant at noon, then we're not surprised that it's going to be potentially keeping them up later. So having them try to dose it earlier in the day, thinking about shifting, if they're on a long-acting formulation, shifting to a medium or short-acting formulation. Other options are to try adding melatonin or an alpha-2 agonist to help with kind of the wind down and sleep. And then you could also think about switching to an alpha-2 agonist or atomoxetine. And I'd say the sleep is another one where it's helpful to have a sense of their baseline sleep patterns before starting the stimulant, because ADHD also, sleep problems are very commonly comorbid with ADHD, and often even without the stimulant, they may be kids that are like have trouble winding down for bed, getting in bed, falling asleep. So that we commonly see that. And then if there's issues with rebound, can think about trying to switch to a longer acting agent where there's a more gradual decrease in the level of the stimulant, or considering after adding an afternoon booster to help smooth that out. Sometimes an alpha agonist in the afternoon, evening can help with that as well. And then in terms of choosing a stimulant, there's a lot of different choices, which can be kind of overwhelming at times. One of the first things to think about is the mode of administration. So are they able to swallow pills or not? There are a lot of choices. So if they can't swallow pills, there's a number of capsules that can be opened and sprinkled. There's also chewable, liquid, and patch options as well. It's also helpful to think about the duration of action and kind of what their needs are. Is this a younger kid where they have a relatively short school day and not really any homework? Then maybe a short or medium acting might be a better fit. Is this a teenager has a long high school day plus activities plus a couple of hours of homework? Then thinking more about a longer acting option might be a better fit. At this point, there's really not evidence for pharmacogenetic testing to help with kind of clinically choosing a stimulant. And then the ADHD medication guide can be a helpful resource that you can see it here. It has pictures of all the different ADHD medications and kind of notes the different liquid and chewable and sprinkleable ones as well. And then this is a slide that kind of covers some of the things to think about in terms of monitoring. I'm going to leave this, it'll be in the slides as a reference, but I'm going to skip over it for time. And then in terms of medications, we think the first line one's stimulants. So generally try a stimulant in the methylphenidate or amphetamine group. If they do well with it, great. If there's issues with lack of benefit or side effects, we switch to a stimulant in the other group. If there continue to be issues with side effects or lack of benefit, then we think about switching to a non-stimulant, so either an alpha agonist or a norepinephrine reuptake inhibitor. With the alpha agonists, there's guanfacine and clonidine, and there's both short-acting and long-acting preparations. We do see significant improvements in ADHD, but this tends to have a smaller effect size than stimulants, so effect size of more of 0.5 to 0.6 rather than 1. In terms of side effects, the side effects listed are somnolence, fatigue, and sedation. So it can make people tired. And often, we'll go into more detail on that. Some less common ones, sometimes headache or nausea. Think about hypotension or dizziness, and rare reports of hallucinations with guanfacine. A notable side effect that's not present is that we don't tend to see changes in body weight with the alpha agonist. So it's a nice choice in those kids that have had issues with weight gain or weight loss with stimulants. And then in terms of the side effects, if there's issues with tiredness, kind of dosing it at bedtime or twice a day can kind of help minimize that effect. Also starting slowly and working up gradually can be helpful, and clinically guanfacine tends to be less sedating than clonidine. So if that can be helpful if the fatigue is a concern. And then in terms of the concerns about low blood pressure, dizziness, making sure they're staying well hydrated, kind of sitting up slowly after they've been lying down a while, monitoring blood pressure. Often it's something where kind of when they first started or first increase the dose, they'll notice it, and then kind of their body adjusts and they won't have that anymore. But if it's persistent, then thinking about lowering the dose or switching medications. And then with atomoxetine, that's one of the two norepinephrine reuptake inhibitors. This one kind of also has an effect size of around 0.6. And some common side effects would be weight loss or kind of gastrointestinal symptoms, stomach aches. One thing that can help is starting at a low dose and starting with the dose split BID. So kind of starting by dosing it twice a day. And then once they're kind of used to the dose, then you can switch it to daily dosing to help simplify things. And then with the atomoxetine, this one does have a black box warning, similar to the SSRIs. So that's something we warn people about, but they're really kind of in later studies hasn't something we warn people about because the warning is there, but there really isn't a lot of evidence for increase in suicidal ideation, and there's no evidence of increase in suicidal behavior. And then in terms of viloxazine, this is one of the newest ADHD medications. It was FDA approved for ADHD in 2021, though has been used longer in Europe for MDD. And it is a norepinephrine reuptake inhibitor similar to atomoxetine, but also increases serotonin and dopamine in the prefrontal cortex. It also has an effect size of around 0.6. A nice thing about viloxazine is while it's a capsule, it can also be opened and sprinkled, whereas atomoxetine has to be swallowed whole. So it can be a good option if you're wanting to do a norepinephrine reuptake inhibitor, but the kid can't swallow pills. Viloxazine is a good choice. And this one is kind of common side effects as it may make them more tired, maybe some decreased appetite or nausea. Kind of starting in a low dose and working your way up can help with that. And then very rare serious side effects of concern for possible increased SI or activation of. So probably wouldn't be one you'd want to choose in a patient where you had concerns about both bipolar or mania. So then Here we have just an algorithm that kind of goes through all of that, kind of with all our kids with ADHD, thinking about healthy activities, nutrition, sleep. For the under 6, thinking about behavior therapy first and school accommodations. Over 6, thinking about those as well as then medication. First, starting with one group of stimulants, optimizing that. If there's issues with side effects or no partial response, switch into the other class of stimulants and optimizing that. If there's lack of benefit or side effects with those, then thinking about the non-stimulants, either an NRI or an alpha agonist. And then from there, can switch between them. At this point, it's also a good idea to be checking in on the differential diagnosis. Are there other things going on that are causing these symptoms or kind of might be contributing to lack of response to treatment? Another option to be thinking about, especially in older teens, would be bupropion. And then in terms of sleep problems, always encouraging sleep hygiene. We know behavioral strategies are the most effective for sleep, but can also then think about melatonin or alpha agonists. And throughout, keep in mind CalMAP and that, we're always happy to consult in any part of that process.
Great. We can take down the slides. Would love it at this point if people can come on camera just so we can have like a little bit more discussion here.